Today I'm going to present diagnosis and management of infectious and non-infectious pulmonary complication in BMT. Uh, my objectives will be the next slide. My objectives will be a brief description of respiratory system, discuss pulmonary complication, classification of pulmonary complication, discuss the epidemiology, understand the clinical manifestation, diagnosis, medical management, and the nursing management. So next slide. Sir, I have shared a video with you. Can you please play that video?
Yes, let me see.
That's a short video on the pneumonia, which will make the better understanding about the how the pneumonia
Pneumonia is a common
use
infection of the
different
lungs, affecting
symptoms.
mostly the microscopic air sacs.
I don't know
the
if they hear
alveoli. The function of the respiratory system is to exchange oxygen
you
and
see
carbon
it?
dioxide between the body and the
Sir,
environment.
it is visible.
Yes, sir.
This process takes place in the alveoli of
Yeah,
the lung.
the audio, I'm not sure
Inhaled
is
oxygen
audible.
moves from the alveoli into the blood and the capillaries, while carbon dioxide relocates from the blood to the alveoli to be exhaled out of the body. In people with pneumonia, these air sacs are filled with fluid or pus, hindering the gas exchange process, resulting in difficulty breathing and a cough reflex. Other symptoms may include chest pain, fever, chills, and confusion. Pneumonia is not a single disease. A large number of various organisms can cause pneumonia. Bacterial pneumonia is the most common, with Streptococcus pneumoniae being the main culprit. Viral pneumonia is more common in young children. A variety of viruses are implicated, with each of them predominating in different times of the year. Pneumonia commonly starts as an infection of the upper respiratory tract, a cold or flu, which then spreads to the lungs. The most common routes of transmission are through inhalation of contaminated aerosol droplets and aspiration of oral bacteria into the lungs. The setting in which pneumonia develops is important information as it helps to identify the source of the causative agent and hence the treatment approach. Generally, community-acquired pneumonia is less dangerous than healthcare-associated, hospital-acquired, or ventilator-associated pneumonia. This is because an infection contracted outside healthcare facilities is less likely to involve multi-drug resistant bacteria. Patients who are already in hospitals are more likely to have other health problems and weakened immune system, and are thus less able to fight the disease. Pneumonia is often diagnosed based on physical exams and a chest x-ray. Clinical assessment for children is primarily based on a rapid respiratory rate, the cough, presence of lower chest wall and drawing, and the level of consciousness. Adults are usually checked for vital signs and presence of chest crackles. Bacterial pneumonia is treated with antibiotics. The choice of antibiotics depends on the patient's age, health conditions, and how the infection was acquired. Viral pneumonia caused by influenza viruses may be treated with antiviral drugs. Hospitalization may be required for severe cases with breathing difficulty, especially for young children, the elderly, and those with other health problems.
So now, sir, move to the slide.
Yes. Okay.
Now I will briefly describe the respiratory system that it is divided into two parts, like upper respiratory tract and lower respiratory tract. Now, sir, next slide. This is basically the anatomy in the of the upper and lower respiratory tract, and we all know better about it. It's just a briefly description of that anatomy, that upper respiratory tract contain nasal, oral cavity, nasal cavity, oral cavity, pharynx, epiglottis, and then in the lower there is trachea and the bronchial tree and the lungs. And so next slide, sir. Physiology of the respiratory system is the pulmonary ventilation, inhalation, and exhalation, external respiration, moving air from the lungs to the pulmonary capillaries. regulation of pH altered by altered by changing blood carbon dioxide level, production of sound, and provision of olfactory sensation. Next slide, sir. Pulmonary complication. Pulmonary complications in BMT recipe defined as a development of one or more of the following: wheezing, increased work of breathing, crackles on auscultation of the chest. Next, sir. Incidents like the epidemiology of the pulmonary complications is in bone marrow transplant recipients is like 25 to 55%, and and the further the classification is the infectious and the non-infectious. Next, sir. This is basically the timeline of complication that how these complications happen in the bone marrow transplant patient, like in the pre-engraftment period, the early post-transplantation period, and the late post-transplantation period. The pre-engraftment is 0 to 30, and early is 31 to 100, and the late phase is the more the above 100 days. And I think they have very briefly described the non-infectious, that which complications happen in the pre-engraftment phase and the early and the late transplantation phase. The next slide, sir. The infectious complication, pulmonary complication, which are caused by pathogens like bacteria, virus, and fungus. These pulmonary complications are more common in patients who have undergone allogenic transplantation because the recipients require the administration of immunosuppressive agents after transplantation to prevent or treat GVH. Next slide, sir. Classification of infectious pulmonary complication is bacterial, viral, and fungal. Bacterial infections account for approximately 90% of infections during the peri-engraftment period after allo bone marrow transplant. A nationwide study of allo HCG recipient revealed that 44% of the pneumonias were due to bacterial etiology. Next slide, sir. The risk factors is developing bacterial pneumonia is the most common is the neutropenia, like in the neutropenic phase. In the engraftment phase, the patient developed the bacterial pneumonias the patient with the hypohemoglobinemias and in the severe mucositis, swallowing difficulties, and with the aspiration. Common causative agents are gram-positive Streptococcus pneumoniae and gram-negative Pseudomonas aeruginosa and Klebsiella pneumoniae and E. coli. The next slide, sir. This is the the description of radiological description of bacterial pneumonia, which showing that bacteria has involved a single lobe of the lung. The next, sir. Viral pneumonias reported 19% in the HSCT patients. Most commonly the CMV COVID-19, which is nowadays a big challenge for the healthcare physicians to deal with it. And further are the which mostly happen in the post-transplant phase, like influenza virus, RSV, and the para-influenza virus. I will discuss about the CMV pneumonia, which is more common in the bone marrow transplant patient. CMV, little description of cytomegalovirus, is a member of herpes virus family, which include herpes simplex, HSV 1 and 2, varicella zoster, and Epstein-Barr virus. HS hematopoietic stem cell transplant recipient are higher risk for developing CMV pneumonia. In absence of antiviral prophylaxis, the reported incidence of CMV pneumonia after allogenic procedure is 20 to 35%, compared with only 1 to 6% after autologous transplantation. Next slide, sir. Risk factors are allogenic SHG recipients are at higher risk for CMV reactivation, which may develop into the CMV pneumonia. Risk is highest in the seropositive recipient who receives hematopoietic stem cells from seronegative donor. Another risk factor is prolonged immunosuppression, particularly the use of corticosteroids. Next slide, sir. So this is basically the description of radiological description of CMV pneumonia, including both lungs that involve the both lungs of the patient. Like mostly the basic difference between the viral and viral, bacterial, and fungal is that the bacterial involve the single lobe or the one side of the lung, but in viral it involved the whole both lung. It involved both lung. Uh, like this radiological presentation is showing. Next slide, sir. Fungal pneumonia. Patient reported 29% of fungal pneumonia. The most common which happen is aspergillosis, and for the Candida and monocytic cerevisiae is rare because we give the prophylactic doses of cotramazole, and for Candida we already we prophylactically give fluconazole, so that's why their incidence is low as compared to aspergillosis. Next slide, sir. The invasive aspergillosis stands one of the most devastating complications. Both allogenic and autologous recipient are at risk, increased risk for invasive aspergillosis during the pre-engraftment phase, when neutropenia is prevailing risk factor. Diagnosis: there is the halo sign on HRCT and sputum culture. Next, sir. This is the typical presentation of invasive aspergillosis on a HRCT, showing the halo sign on the HRCT. Next, sir. This is basically the I have written the basic differences: radiographical appearance of bacterial, viral, and fungal pneumonia. In bacterial, it attack one lobe or a section, causing specific area of inflammation, sir. Next slide, sir. And in the viral viruses, as I have already explained, that viruses affect both sides of the lung by producing more homogeneous inflammatory reaction that causes increased cellular debris and mucus. Next, sir. In the fungal pneumonia, the multifocal non-segmental consolidation occurs significantly. Large nodules with the halo sign, as I have already described that in the aspergillosis pneumonia, the halo sign is more common, and it is very easy to diagnose on the HRCT on the basis of halo sign that whether the pneumonia is bacterial, viral, or fungal. Next slide, sir. This is the pulmonary complication and the radiological findings, which are showing on different pneumonias like bacterial, viral, pneumocytic cerevisiae, and CMV-induced pneumonia. Now we can see on the radiological finding that in the bacterial it is segmental or only a lobe consolidation, and in the aspergillosis pneumonia, halo sign, as I already described, that halo sign segmental, subsegmental, and plural-based consolidations. And in the monocytes, cerevisiae, widespread of perihalar ground glass opacities, and in the CMV, in micronodules and the airspace consolidation, which involve both lungs. Next, sir. Next slide, sir. So this is another picture which is showing the different radiological presentation. I think move to the next slide. Diagnosis. Mainly the diagnosis of is done on the basis of chest X-ray and HRCT, as the patient complain about the shortness of breath or pleuritic pain or and the decreased oxygen saturation on pulse oximeter, we move to do the chest X-ray or HRCT. Further, if the patient has fever, we do the blood culture. If the pneumonia has the pneumonia causing pathogen has moved to the blood, then it will appear on the blood culture, that which will show the bacteremia. And further, PCT levels. PCT levels are very helpful in detecting the bacterial infections, because when we the diagnosis were were difficult in the presence of fever and all those symptoms, we usually do the PCT level, which show higher range in bacterial infections. Further, the nasopharyngeal swabs in viral infections and the sputum culture and the beta D glucan and galactomannan assay for fungal infections. Sir, I have some question regarding that. That I have I have gone through some studies which are showing that with tazocin, the galactomannan assay and beta D glucan levels are show the false positivity in the patients who were receiving the tazocin. So I will share the study with you. And further, we do the bronchoalveolar lavage for rapid culture and lung tissue biopsy.
Yes,
Next,
Amur, let me comment on this. Yes, you're right.
yes,
There are some drugs like tazobactam that can give a false positive result on the galactomannan test. In fact, the American Society of Clinical Oncology in their guidelines, they do not recommend to get galactomannan tests. So it's pretty useless. So the mainstay of diagnosis of aspergillosis is the chest CT.
CT, yes, sir.
Galactomannan is not very helpful. In general, it's not recommended.
Okay.
Okay.
Thank you, sir. Next slide,
You're
sir.
welcome. Yes.
Prevention. For the prevention of infectious pulmonary complication, as we can do the minimize the visiting of patient room. Use of proper PPEs while attending the patient, like proper wearing mask, cap, gown, to prevent the infection, to cross contamination, and mostly we do not allow a person who has a fever or cough or flu or any other infectious disease to meet the patient, because our allogenic patients are highly immunosuppressed, so they have the higher risk of getting infection. The minimum handling of CVP to prevent central line associated bacterial infections, because these bacterial infections could lead to the pneumonia, and maintain aseptic measure by handling the patient, and use of HEPA filters for air filtration. Because some studies I have gone through that shown that for fungal infection, if we have a HEPA filtration in the room, the risk of getting fungal infection becomes lower as compared to without the unit without the HEPA filters. The next slide, sir. Management for bacterial are a broad spectrum antibiotics covering both gram-positive and gram-negative. As we always give start with the tazocin and the meropenem. Next slide, sir. Management of fungal, as we prophylactically start fluconazole for Candida, so the incidence of Candida pneumonia is very low. And other voriconazole 6 mg per kg for first 24 hours, and 4 mg per kg IV or oral for as a BD. It is the first line treatment for aspergillosis. We usually do not move to the amphotericin B or amphotericin B liposomal, because they have their own consequences, because the patient need to be admitted for that drug. So voriconazole is easily available on the in the tablet form, so we can treat with the patient on the oral voriconazole as well. The important thing which we need to monitor with giving voriconazole to the allogenic transplanted patient, that we need to monitor the CSA level of that patient, because voriconazole interact with the CSA and give rise to the CSA level. So it may cause the CSA toxicity in the patient patient of allogenic acidity. So we need to monitor closely the CSA level of CSA level with voriconazole and adjust the dose accordingly. So next slide, sir. For the viral one, we prophylactically start acyclovir. So the RSV, the influenza virus, and parainfluenza virus is rare in the pre-engraftment or in the peri-engraftment phase, due to this prophylactic administration of acyclovir. For CMV pneumonia, we when we give the patient, because the CMV pneumonia happens in the after most in the post-transplant phase from day 30 to 100. So it's almost the day of patient discharge. So if the patient has a CMV, so we start with the ganciclovir or valganciclovir. Ganciclovir is the IV form, which we start according to 5 mg per kg Q12 hours. And the valganciclovir is the oral form, and it is given on the basis of BSA and the creatinine clearance. So next slide, sir. Non-infectious lung injury following HCT may represent up to 50% of after allo-HCT. Next slide, sir. There are different types of non-infectious pulmonary complications, that peri-engraftment respiratory distress syndrome, pulmonary edema, idiopathic pneumonia syndrome, diffuse alveolar hemorrhage, and cryptogenic organic pneumonia and bronchiolitis obliterans syndrome. Next slide, sir. Peri-engraftment reported incidence with the propensity to occur more frequently in allogenic transplant patients. It is one of the earliest non-infectious pulmonary complications occurring on the average 7-day post-transplant, with the average time to onset between 5 to 21 days. Diagnosis: the Spitzer diagnostic criteria for engraftment syndrome include major criteria for non-infectious fever, erythematous rash, non-cardiogenic pulmonary edema with the minor criteria for weight gain, and the hepatic and renal dysfunction. Next slide, sir. Treatment consists of short course of corticosteroid with reports of rapid improvement within 24 to 48 hours of corticosteroid initiation.
Yes, Tamur, let me make a very brief comment here. I know that
Yes,
adult hematologists use steroids routinely for engraftment syndromes, but in children at least, the engraftment syndrome almost always resolves by fluid restriction and diuresis. And so we, of course, as you mentioned, steroids, then if one uses it for engraftment syndrome, and most of the time it can be avoided, of course you pay the price later in terms of CMV reactivation. So in general, for engraftment syndrome, we try to stay away from steroids, and we sort of stress more fluid restriction and diuresis. Okay.
Yes, sir. And the second is the pulmonary edema. As a consequence of fluid overload, incidence is observed in 60% of patients in the first days after transplant. The exact incidence of pulmonary edema is not established, although it could be higher than 20%. Supportive measures are O2 therapy according to requirement, and the spirometry and the management medical. We manage, we stop we hold the intravenous fluids and give the diuretics for that. Mostly the non-cardiogenic pulmonary edema get resolved with the diuretics. P presentation, sir. Next slide, sir, please. So this is the typical radiological presentation of pulmonary edema on the CT, that is showing the enlarged pulmonary vessels. So when we do the HRCT, this is the presentation of pulmonary edema. Next slide, sir. Then we will discuss about the DAH, diffuse alveolar hemorrhage. DAH is a relevant cause of acute respiratory failure that occurs in 2 to 14% of recipients, with similar incidence in both auto and allo transplant recipients. Diagnosis: the diagnostic criteria for DAH include multilobar pulmonary opacities and progressively bloodier return at the bronchoalveolar lavage in the absence of infection. The finding of more than 20% hemostrident macrophages in the bronchoalveolar lavage fluid is suggestive of DAH. Treatment mostly done with the methylprednisolone 250 to 500 mg to 6 hourly and over 5 days. Next slide, sir. The clinical presentation of all the pulmonary and non-pulmonary complications include fever, and non-infectious fever may or may not be present. So in the infectious one, fever will be present. SOB is a common clinical symptom in both infectious and non-infectious pulmonary complication. Productive cough may be present in the bacterial and the viral, and in the non-infectious, productive cough may not be present. Pleuritic chest pain is another clinical symptom. Next, sir. Physical examination show fever, tachypnea, tachycardia, and decreased O2 saturation below 90%, decreased breath sounds, dullness to percussion, and on the auscultation we found rales and rhonchi and egophony on the auscultation. Next, sir. Here's the nursing management, which I will discuss, that all the nursing management based upon the clinical symptoms of the patient. Like the patient has a fever above 101 or 102, that we can do the tepid sponging. And if the patient has the shortness of breath, so we can start the O2 therapy according to the maintaining the oxygen saturation. And the we can do in the nursing management, we do the steam inhalation and the uh, steam inhalation. And the further is like in the nursing management, as we give the according to as we give the medicines according to the advice of doctor. And the for mainly it is based upon the clinical symptom that we found in the patient of infectious and non-infectious, with the pulmonary, with the non-infectious and infectious pulmonary complication. So nursing management uh, is I need, it's all from my side, sir.
Okay.
Any question?
Okay. Thank you, Tamur. So I just want to make two sort of brief comments. The one is you mentioned that for pneumocystic uroveci, I think you said, I know that you meant cotrimoxazole, but you said cotrimazole. So I just want to.
That's what was the pronunciation
Yeah,
problem.
right. Yeah, but because I also sometimes get confused also in the order sheet. So cotrimazole is to prevent oral candida, so thrush, and of course is given as an oral solution. Of course, cotrimoxazole can be given as oral solution, but is also called Bactrim or Septran. Okay. And then the other thing I just wanted to point out is that I think you mentioned that for acyclovir, we also give for parainfluenza, influenza, but I don't think acyclovir is very active against those viruses that, at least in our patient population, are normally not a very big problem. Some people use Tamiflu, but I think that the activity is questionable. So we use acyclovir essentially to prevent